Updated budget deck. Do you need Lisa to speak to that last slide?
No,
Okay.
just the here. Bring the budget deck over here. I'll show you. Okay, well, in the words of Governor Daniels, former Governor Daniels, let's not penalize the punctual. So, Lindsay, do you want to start off?
I would love to. Can everyone see my screen in the Medicaid Advisory Committee presentation?
Yes.
Okay, thank you. Welcome to the MAC meeting. If you are a MAC member, I would like to ask that you type your name into the chat function of the screen in the Zoom link, and we will record your attendance. Our agenda today is the MAC updates and formation of the Benefit Advisory Council, which will be presented by Charity Lumpkin. We will have a discussion on HIP 3.0 by Secretary Robe. We will talk about the Medicaid challenges with Secretary Robe, and then the meeting will be adjourned. So I would like to turn it over to Charity. And Charity, when you are ready for the next slide, if you would just let me know, I will advance them for you.
Where do we sign our name? I'm sorry.
Hello, Senator Charbonneau.
Yeah.
I have you down, so you don't need to do anything. But
okay.
Anyone else, you can just enter your name in the Zoom chat.
I got it. Thank you.
Before we get started, I've got a agenda in front of me that says approval of the February 2025 minutes. So I'm supposed to.
I'll move approval.
Do I hear a second?
Second.
Been moved and seconded. All in favor, please say aye.
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 All opposed? The chair hears unanimous approval.
Well done.
I learned this from you, Senator.
Yeah.
Okay, I think we'll go ahead and get started with the information about the Medicaid Advisory Committee changes and the formation of the BAC. So this is a high-level overview of the Medicaid Advisory Committee changes and the formation of the Beneficiary Advisory Committee or Council. Next slide, please. So the Medicaid Advisory Committee and the Beneficiary Advisory Council have changes that are coming up that came about as CMS created and finalized the access rule in April of 2024. It establishes new requirements for our MAC, and it does create a Beneficiary Advisory Council for each state. And the goal of this rule is to ensure that Medicaid programs across the United States reflect persons with lived experience and to increase transparency and accountability through bidirectional feedback. So from members to the committee and to the Medicaid as a whole, and then from Medicaid to our members.
Lindsay or Charity, can you pull the slide deck up?
I have the slide deck up. Is it not showing? Did it?
Not on mine.
I can see it.
I can see it.
I do too, yeah.
All right, well, I know what it says, so it's fine.
Okay.
Next slide. So the Medicaid Advisory Committee changes. The requirements take effect July 9th. The requirements allow or require the MAC meetings to have 2 meetings a year that are open to the public and are open for public comment. We have to post information on the MAC in the back. So we have to post our meeting minutes, agendas, and all those that are in attendance. We need to collaborate or it works on to collaborate with the back to determine topics to discuss. So again, that bi-directional feedback. The MAC develops an annual report for CMS, and that first report is due July 9th of 2026. And it is also a part of the changes is to increase MAC back crossover membership. It starts out as 10% this year, July of 2025, and it goes up to 25% July of 2027. And our General Assembly already put those numbers into play based on Senate Rule 486. Next slide.
Maybe it's just my picture.
That's you.
So preparing for the MAC changes, like I said, Senate Enrolled Act 486, I think I misspoke, so it's 486, does change the membership of our MAC. And so 16 members are appointed by the Medicaid director and 8 members are appointed by the General Assembly through legislative appointments. Next slide. MAC membership, 10 members are not or non-BAC members. We will have BAC participation on our MAC. So non-BAC and non-legislative members will be appointed by the Medicaid director. Those persons interested must complete a MAC application. The application can be found at this link, FSSA Medicaid Policy Advisory Committee. Applications will be accepted until July 27th, and applications should be emailed to mac@fssa.in.gov. And in that subject line, it needs to be MAC application. So these members, 6 members will be appointed by the Medicaid director based on their appointment to the Beneficiary Advisory Council. Again, that bi-directional feedback. And then 8 members will be appointed by the Indiana General Assembly and approved by the Medicaid director. These individuals do not need to complete the MAC application. So there are 10 open slots for individuals to apply for participation on the MAC. Next slide.
I just wanted to point out that the date for the applications is June 27th.
Not July, I apologize. June 27th. I'm hopping a month early. MAC membership applicants for the 10 positions will be notified during the summer if they're selected. So the breakdown of those 10 members, 6 members represent Medicaid providers with no more than 1 representative from each Medicaid type, 2 members representing managed care entities, and 2 members representing either a state or local consumer advocacy group, other community-based organizations that represent the interest of or provide direct services to Medicaid beneficiaries. So that is the 10 members that need to, individuals who will be appointed based on the application process. Next slide, please. Current MAC members, we so very much thank you for your service. This will be your last meeting as a MAC member unless you become reappointed in that new process that we just discussed. Next slide. MAC contact information can be found here. There is a new website for those applications to be sent to, mac@fssa.in.gov. They can also be mailed in to the address listed below, and that is the Office of Medicaid Policy and Planning address here at the Government Center South. Next slide. The Beneficiary Advisory Council. I have been working on this for quite a while, and I'm so excited to get to talk to you all about the Beneficiary Advisory Council, or the BAC. So the advisory group is comprised exclusively of Medicaid enrollees or their family members or caregivers. These caregivers can be paid or unpaid caregivers, and they will. It's a group that provides dedicated opportunities for people with lived experience on the Medicaid program, to identify key issues to bring to the MAC, to advise the state directly on policy and administration concerns or ideas. The requirement takes effect July the 9th, and the final increase to 25% crossover has to be completed by July 11th of 2027. Next slide. So why are we doing the back makeup? What is this for? So back membership, like I said, is for bidirectional feedback between the MAC and the state and our members. So we know that Medicaid members are a varied group. And so members may represent more than one type or one area of Medicaid. The application seeks to learn as much about an individual, their history with Medicaid, their ongoing history, as well as possibly their past history with Medicaid. So we can really try to get a varied group of individuals on our back. A spreadsheet's been developed and will be used to organize members' answers to the application. So again, we can try to get a varied group of Hoosier population on our back. OMPP staff will then screen applicants, will interview potential members, and then the Medicaid director will appoint participants to the back. Next slide. So again, Senate Enrolled Act 486 already created our back, and now we're in the process of forming that. And so this discusses the 8-member committee that will make up the back. Next slide. So our recruitment strategy for the back. The application link will be posted on the FSSA website and will go live today. And it is live. I went earlier before the meeting started to check on that. Applications can be completed online or can be mailed to OMPP. Applications will be accepted through, it's actually going to be July the 15th instead of July the 18th, but folks will be able to submit applications through July the 15th. MCEs will make the applications accessible from their program sites. They're working on that process now. MCEs will send printed applications to their current MAC attendees. As they get that application available to them, they'll be sending that out. And they will also discuss the back at all of their MAC meetings. So our MCEs, as a part of their contract, are required to have their own MAC meetings. They call them different things, but it brings in their membership, caregivers, community involved individuals to talk about what they're seeing with their MCE. And so if they have individuals that are participating on that committee, we would like to look at them to possibly participate on our committee as well. Next slide. We're also having the DFR, the Division of Family Resources, post flyers in their office. We know that lots of folks travel in and out of our DFR in order to submit documents and apply. And so they'll be able to apply from a QR code that'll be at the DFR, as well as front desk staff will be able to assist them in scanning that or printing off an application if that's needed. The email address to send an application is back@fssa.in.gov. We'd like that subject line to be back application. 4 members will be appointed by the Indiana General Assembly and approved by the Medicaid director. These individuals do not have to complete the back application, and we expect the back to be in place by the end of September of 2025. Next slide. So the back application process, applications can be submitted mail or electronic. Again, I said there's a QR code. It's also a Microsoft form, so folks will be able to just submit it from that form. OMPP staff will screen all applicants to try to mirror the varied Hoosier Medicaid population. Again, we want as much variety on our 8-member committee as possible. Demographics from the applications uploaded to the back member composition tracker. And then myself or another member of the OMPP team will be completing interviews with those members, beneficiaries that we think might be a good fit for the back. And then we will be making recommendations to the Medicaid director for appointment. Next slide. The back contact information is back at fssa.in.gov, and then snail mail can be sent to my attention here at the Government Center South. I'll also say that there is now a back, when you go to the MAC site on the FSSA site, there's also now a back page. So we weren't sure if that was going to go live at this point, but it did go live today as well. Next slide, please. And that's the presentation on the MAC and the back.
Charity, thank you very much for that. Does anyone have any questions regarding what Charity went through? All right. Thank you again, Charity.
Lindsay.
Oh, yes.
Sorry, I was unmuting. This is Katie Stafford Cunningham with NRF. I found the information on the application for the MAC. It doesn't say where we should submit that. What was the email address? I didn't catch it on
MAC,
the slide.
MAC at fssa.in.gov.
Thank you.
You're welcome.
Lindsay, this is Shane Springer with the Indiana Dental Association. Will these slides be available to current MAC members? I understand this is our last meeting altogether, but that was awesome presentation, Charity. Great information. We just went through fast. It'd be great to kind of walk through it a little bit slower within our internal organization here.
Sure, of course. All the slides from all of the MAC meetings are always posted to our website, so we can send out that link for you too.
Great, thank you.
Mm-hmm. Any other questions?
Hi, Lindsay. This is Julia Kettner with IFCA. Did I hear that the new MAC would have a limited 10-member cap, or did I hear that wrong?
There are 10 members that are non-BAC members and non-legislator members that will be appointed by the Medicaid director. Yes.
Okay.
Okay, I will turn it over to Secretary Rope, who will discuss HIP 3.0.
Thank you, Lindsay. Let's see, if you could advance to the next slide. This has been a circuitous route with the Healthy Indiana Plan, and we're by no means done with that. When the Rose decision occurred almost a year ago, it abolished our ability to do any kind of cost sharing or do any kind of material holding members accountable for some of their behavior in return for decreased prices. So if you could flip to the next slide, please. So as my wife likes to say, Indiana needs a hip replacement. And she tells me that I have to footnote her on this because she's copyrighted this, and I don't want to get in any more trouble. So Senate Bill 2 and the big beautiful bill will have a work requirement. So we will be working through that work requirement over the course of the summer in terms of how we wish to administer it. For those of you who remember, the previous administration attempted to roll out a work requirement before the COVID emergency happened, and then put it back in the box, and it's that work requirement is going to stay in the box. So we're not going to be we're going to pull something out that's, we hope, much easier to administer. According to the big beautiful bill, there will be member engagement and some degree of skin in the game for that individual with cost sharing requirements. We are also hopeful that the big beautiful bill allows us to return to a situation where we have incentivized wellness in that bill. That is currently not in the bill, but we have been working with our delegation, asking them to include language to give the Secretary of HHS the authority to approve waivers that would do so. Let me then talk a little bit about what we learned for some of you last night, for most of us this morning, when we looked at the text of the Senate big beautiful bill that was released. It significantly decreases the amount of it significantly reduces the tax rate that we can have for a hospital assessment fee or other provider taxes. This will put the current incarnation of the HIP plan at significant risk, because candidly, we don't have the general revenue fund dollars necessary to make up the difference. So if that were to pass, we're going to have some very difficult conversations to have in the coming legislative sessions. And so I alert you to that. One of the things that we have asked, that we will be asking, I have asked, and I will run around Washington, D.C. with my hair on fire until we get this, is the ability to go from a mandatory number of people in the Medicaid program, rather a mandatory expansion using a state plan amendment, to a waiver amendment that continues to allow us to use the highest, and right now, 910 money, but may allow us to, we may have to cap that program financially. That's unfortunately, that's a reality. If the 3.5% cap were to go into effect. So I wanted to make members aware of that news this afternoon as well. And then I wanted to run through some of the other Medicaid challenges that we have. Some of you have seen these slides, some of you have not. So the first is, this is the growth of ABA therapy. And this is emblematic of many of the other program growth that we've seen. Back in 2017, we were spending $21 million for ABA therapy. In 2023, that had grown to $611 million. That is a 2,867% growth over that period of time. That clearly is not something that we can deal with. And the percentage of Medicaid spending from 0.2% to 3.4%. So as some of you are aware, we have a group this summer that is studying how to control the cost growth trajectory of this product, and it's something that's absolutely essential for us to accomplish. The next slide you'll see is the cost growth trajectory in the attendant care acceleration. So in let's say August of 2021, we were spending about $15 million a month. By March of 2024, we were spending approximately $85 million a month. So if you look at that blue bar, you'll see the amount of blue there describes the number of dollars we're spending for care over 60 hours a month. Rather 60 hours a week, pardon me. And that's just an extraordinary amount of care. So in both cases, in both of the previous slides, both the previous slide and this slide that I showed you, we end up in a situation where we have inadvertently created a dependency, right? Many of us have our caregivers or care supervisors for our elderly parents, and we know that once they lose the ability to do something, it is, to say the least, rare that they are ever able to habilitate to that situation again. So we've created these dependencies for many of these seniors who are living in the community, but at a price that we simply can't afford. So let's look at the aggregate. So Senator Charbonneau, you'll remember this slide. You flip to the next slide, please. The amount of
Oh, yeah.
The forecasted general fund assistance need in 2017 was $1.9 billion. Next slide, please. The forecasted budget need for Medicaid in 2027, so 10 years later, is $5.2 billion. This is growing at a rate, and this is well before and well after COVID. So you just take COVID out. I mean, everybody talks about COVID. COVID is in the rearview mirror, and we need to be aware that we cannot afford this growth rate, this kind of trajectory. We've got to figure out a way to build a delivery system that can live with the growth rate of the Indiana General Revenue Fund. And we're not going to have the federal government to go rely on, to go get more dollars from, as we have in the past. So this will require, and I'm talking to all of the representatives of the more traditional Medicaid, both recipients and the providers. We're going to have to design a plan that grows at the rate of the general fund revenue growth, both in terms of, and that's going to mean either significantly limiting the amount of care we can afford to provide, or finding better, faster, cheaper, primarily cheaper ways to provide that care. Because, this is our next slide. Because we've been on the last buffalo hunt, right? The last buffalo hunt is what we're trying to do. We're trying to get in under the wire. We'll talk more about this tomorrow at the Budget Committee, how we've submitted the MCAF, how we've submitted a new hospital assessment fee, that we're doing our very best to get in under the wire. But even if we succeed, it is doubtful that my successors or the governor's successor will be able to go to Washington hat in hand and ask for more money to prop up this program. We're going to be on our own with this program, and we need to figure out ways to work within the constraints of the Indiana General Revenue Fund. Is that the last slide? And it's not. So why is this important? Because every dollar we send to a hospital is a dollar we do not send to a school. Every dollar we give to a doctor is a dollar we do not give to a teacher. This is a stark reality, but this reality is going to be the reality that the governor and the General Assembly will face in 2027, which is not too far from here. So we have no choice but to work through that. And I think I've referenced this earlier today. The current developments, as of today, the U.S. Senate version of the Big Beautiful Bill caps provider taxes at 3.5%. If signed into law, this will require the state of Indiana to significantly roll back eligibility for the Healthy Indiana program, and we would need explicit language in the bill to do so. So I recognize that I am Mr. Glass half empty here, to say the least. But as most of you are aware, I rarely candy coat the truth. So I would be happy to try and answer questions from members of the committee, or we can just all go and start crying in the corner.
Secretary Rowe, this is Fadi. Is that okay to ask a couple of questions?
Of course.
Well, thank you for your presentation. I've always enjoyed working with you, and you are correct. You've been always honest with me in presenting data and information. I have two specific questions. The first question, you made a comment that the growth of the program has to align with the growth in general fund. While I appreciate the fiscal concern, and we have to be mindful of fiscal issues, I have not heard you speak about how we will address the underlying issues, which is the healthcare, the quality of healthcare for Hoosiers. So what happens if our population continues, they will continue to age, and they will continue to struggle with healthcare issues. So solving the problem just by limiting it to the growth of the general fund will not fix the ultimate strategic issue, which is the population is aging, Hoosiers might not feel well, they have
Yeah.
health issues, and we can control Medicaid for several decades to come by limiting the fiscal impact, but that does not get rid of the health issue or the health concerns of our citizens. So that's the first question. I'll pause to get your thoughts on that, and then I'll share my second question.
Well, if I thought so, I mean, this comes down. So in 1995, I wrote a policy piece for then candidate Steve Goldsmith that said sooner or later during your administration, you're going to be faced with a situation where you're funding the care of the elderly or you're funding the education of children. And Senator, I don't know where else to go with the money, right? I mean, just the stark reality here is that we have been masters of going to Washington, D.C. and finding ways to fund the Indiana Medicaid program. I think that's the last buffalo, and we're currently on the last buffalo hunt, right? I'm going to go out there and get as much as I possibly can before the Medicaid program is put into a box and stuck in a freezer and locked. So we're going to have to find a way to reduce the cost growth trajectory to something that you all members of the General Assembly and the governor is sustainable, right? And what the numbers I've shown you, when you go over a decade, when you go from $2.1 billion to $5.2 billion, I don't think that's a sustainable growth rate. In 10 years, if you're still a member of the Senate representing me in my district, because I don't plan to move, you're going to, at that growth rate, you'd be appropriating something like $12.6 billion for Indiana Medicaid. And I don't think we're going to have that. So either A, we're going to have to reduce I mean, I think you've got a couple choices here. One is reduce the number of eligible people, right? Continue to create wait lists. I don't like that answer. That may be an answer. We're going to have to reduce provider rates, pay providers less, or we're going to have to design a system that can provide care in a less expensive model. And that would be my preference, because the other two are very unpleasant. Now, I don't know, and you'll say, well, have you designed that system yet? No, it's the members of the Medicaid Advisory Committee and others in consultation with us who need to get about the business of doing that, about designing a program that we can afford. So, if the Indiana General Assembly and the governor chose to raise taxes, that would be the other option. I don't see that as being that's outside of my purview. If you guys decide to raise taxes, we will spend it.
I appreciate your answer. I think maybe strategically it might be helpful to look at the analysis of what are the cost drivers as far as specific illnesses, diseases, and then target those strategically through campaigns. I think the program can be smart sized in a surgical way, strategic way to address that. But also, I think I'll defer to the General Assembly on the discussions we had last session on the MCAF and other potential sources of funding. My second and final question, Secretary, is on the comment that every dollar taken away from Medicaid or spent on Medicaid is taking away from a child or a teacher. While mathematically this is correct based on today's budget, a child in a school who's not healthy, who is on Medicaid, and these kids are factored in the educational funding formula. We call it the complexity index for SNAP, TANF, and Medicaid students. So I see it both ways. Is that if we're not taking care of their health, we will also impact their education and vice versa. But the idea is that I think the program can be sustainable if we have a data-driven approach. And I would love to see any reports on dissecting the program to see what are those drivers, what are the healthcare metrics that we're going to pursue to improve the quality of healthcare, and then how we can do that within the money that we have. I fully agree it has to be sustainable financially, but I just don't want to lose sight of the of the healthcare quality piece and the need, the underlying problem that is causing it.
Yeah, so let me comment on that if I may. So those first two, so the way we have begun to look at this is by type of care, right? So the first two slides, looking at the growth rate of ABA therapy, looking at the growth rate of care for attendant care. Those slides are chilling, right? And they're not the only types of care that we've seen that kind of growth rate over the last decade. So we've got to figure out ways to provide care to the patient population that you're looking at now in a more efficient mechanism than we, and not to create a dependency. So I welcome your thoughts. You're a thoughtful fellow about this, and I look forward to working with you.
I appreciate it. I look
Yeah,
forward to working with you too. Thank you.
Thank you, Secretary Rowe. I appreciate your directness. I understand the levity of the situation that we are in, especially looking at the rise in attendant care and thinking about our seniors who do want to stay in their homes. I'm very interested in what is it going to look like? Like, are we putting together teams to look into other models? Because I'm thinking, like, is there some kind of way that we can actually start taking care of people maybe in groups? Not saying they have to be in a nursing home, but how can we like start thinking outside the box?
Those are great questions. So let me give you some quick numbers on this. So for an individual to be cared for in a nursing home by the state of Indiana, if they reach that level of care, and everybody on the scene that you're looking at has, and Lindsay, you'll step in and correct me where I misspeak, please. It costs approximately $98,000 a year in Medicaid money, and about a third of that is general revenue fund money to fund a patient in a nursing home. If they can be funded in an assisted living facility, that costs about $38,000 a year, Lindsay. Is that about right? Am I close?
That's about right.
Yeah, about $38,000 a year in that. And we have many patients on the Pathways program, or many recipients on the Pathways program, who are spending more to care for them in their homes than it would cost for us to care for them in an assisted living facility. And I think we're going to have to ask ourselves and the federal government some very difficult questions about whether or not, to your point, whether or not that makes sense economically for us, because we, I unfortunately I say these lines all the time, and you guys don't. Most of the members here don't have to listen to me all the time the way the poor people at OMPP do. But would we save that baby for $1? Well, of course we all would, right? Would we save the baby for $100? Yes. $1 million, probably. $1 billion, well, we couldn't, right? So at some point in time, as a dispenser of public monies, we have to ask ourselves these difficult questions.
Yeah, I definitely see the questions that we got to ask. I definitely understand. So over the summer, what does that look like for the MAC? Are we going to start looking at other models? Do we need to start doing research on our own and submitting to you information? How is that going to work?
Yeah, I don't know that answer yet. To be honest with you, the sands have shifted so quickly under my feet in Washington, D.C., that I'm trying to stand up doing that. So I wouldn't, unfortunately, apparently I can't walk and chew gum at the same time. So I've got to get the preprint done for the state directed payments. We thought we had that wrapped. Now that's become unwrapped as of this morning, and we have to figure out how to get the preprint is the uses of cash. By the way, the sources of cash are likely to be the MCAF, which I think is unlikely at this point, unfortunately, or the HAF, which I think is likely. we've got to get those those have been sent to DC. We've got to get those taken care of before we can really focus on this piece of it. But I would say early fall, Representative, we're going to put in place a process to try to discern how to drive down the cost, how to unfortunately drive down the cost of these programs to a level that's affordable.
Okay, thank you. I look forward to being a part of that. Thanks.
Senator Charbonneau, is that your with a hand up?
Yes, sir. I'm glad I had my video off and the audio off, because when you mentioned incentivizing wellness, I jumped up and started clapping. Can you talk a little bit about how that would play out?
Yeah.
And it may, you may not be able to at this point in time, but we started the Health First Indiana program, and unfortunately, I don't think it's a hit on the program, but I just didn't have enough money, and so it's been extremely reduced. And you know better than anybody, this is a long-term approach. So, what do you see?
Well, so I'd like to. So the big beautiful bill calls for there to be a premium for able-bodied adults. Okay, there was if you recall correctly, when we passed the original Healthy Indiana plan back in 2007, there was a premium component to that, and you were able to opt yourself out of that premium component if you did certain wellness activities using what's called a power account. Well, it turns out that was doable. That process was kind of doable when you had 10,000 or 15,000 members, but when it grew to 700,000 members, it became unwieldy. So what I would envision is something like this. If given the authority by Congress to do so, I would like the Secretary of HHS to have the authority to reduce the premium that an individual, an able-bodied adult, was paying if they did certain wellness activities, like if it's a female, have a pap smear, as an example. That's not going to save Indiana Medicaid much money in that year, but in the out years, it may save Indiana Medicaid a lot of money, and it could significantly alter the trajectory of that individual's life. If a cervical cancer were discerned sooner rather than later. So that's the kind of thing we're going to try and do currently. And by the way, Senator, we'll be, as you remember, when we designed HIP 1.0, we went on a tour of Indiana to create that benefit package. We intend to do the same thing with HIP 3.0 if we are given the congressional, if Congress gives the authority to the Secretary to allow us to apply for a waiver. Currently, they have not done that, despite the governor and my protests.
Thank you.
Representative Campbell, your hand is up.
Yes. On the graph that you had showed about the increase in pathways, can you respond to it looks like the drastic increase looks like it appears to, when it goes live July 2023, seems like that's when pathways went live, and now we see this huge increase by July 2023. Could you respond to that?
Sure. Pathways, the managed care product, went into effect on July 1st of 2024. So all of those dollars that you're seeing on that graph are dollars that exist in the fee-for-service environment. Apparently there were, and Lindsay, you can correct me if I misspeak here. There was a fee schedule increase in June of 2023 that significantly vaulted ahead our fee schedule from where it was. And this really is the source. The two slides I showed you are honestly the source of the $1 billion miss, because they weren't in the forecast.
Is that when we were required to have parity with Medicare?
Well, you don't have to have parity with Medicare.
Well, I thought we passed a bill that, we had to have, create some parity between reimbursements.
I was playing a lot of golf in that period in my life, so I really can't speak to that. I'm no longer playing a lot of golf, but perhaps Lindsay could respond to that.
You're speaking to the HIP rate equalization, where we had to have parity amongst all of our managed care programs. This was not impacted by that. This was not reflective of that.
Victoria Grace Wilburn, you have your hand up.
Yeah, thank you, Mr. Secretary. Appreciate the information. Is it possible to go back to the slide with the 10-year increase in costs? I think I missed the percentage of growth in the aggregate. Do we know what percentage? 12? Okay, 12.8%. Is that correct?
Well, that's year over year number. So if you look at the 1.9 in 2017 and then fast forward to 2027, it's 5.2. So that's what, 150%? Is that right? Yeah, it's a doubling plus. I don't know. I mean, it's more than double.
Yeah, I was just curious if it was at all representative of the 10-year costs that we've seen nationwide with healthcare in general.
I don't think healthcare has gone up that much over that period of time.
I think the calculations I have are only 8%, so that's why I was curious. I
don't know.
Okay, thank you. And then will these slides be available for our personally? Yes, Lindsay, I see you shaking your head. Okay, thank you so much.
Sure. If you just, we will send the link to the slide deck. I think it might even be at the end. Oh, it is not. Yes, but the FSSA website has a MAC page, and all meeting agendas and slide decks are available there. So we can send you that link.
Okay. All right. Any other questions for the good of the cause? Okay, seeing none, I will move adjournment. Oh no, I will ask if there's a motion for adjournment.
So moved.
So is there a second?
Second.
And all the ayes say yes? All in favor say aye?
Aye.
Hi.
Acclamation. Okay, thank you very much, and look forward to seeing you all in person. Stay tuned for tomorrow's budget committee meeting. It'll be fun.